Thank you very much, and thank you very much for the invitation today. And as always, you find places like this that you've walked past dozens of times over the years and had no idea it was here. So great venue choice as well from that point of view. So I've been asked to talk really, I think, about the returning person from a mass gathering from a clinician's perspective. And I'm a simple clinician, so I just sort of look at it from the patient point of view. And whenever I'm faced with a patient with a temperature, I ask two questions. And the first question is there anything different about this person? And by different about the person, I'm really talking about the characteristics that make them more prone to infections. And that links then a little bit to some things I'll say later on. So is this person pregnant? Are they immunocompromised? What medications are they on? What's happened to them before, etc.? And then the second thing, which is the one patients always ask you, is where did I catch it? Or often, who did I catch it from? And that's really understanding what that person might have been exposed to in the time period before they present with an infection. And that links very much to some of the issues that were being talked about in the last session about the sort of things that may or may not happen when people are at mass gatherings. A standard way that we'll teach medical students and we'll approach the sort of feverish or febrile traveller is to look at the sort of 5 W's about, what's been happening to people and where they are. And if you look in any infectious disease or any travel medicine textbook, you'll find an awful lot about this. You'll hardly ever find anything about what might happen if people are at particular gatherings, what are the sorts of practices that might go on in the mellow or the heart, and the sorts of things we were hearing about earlier on. But in detail, it's really going into where have people been, are there outbreaks going on in those areas at the time, when they came back, very important in relation to the sorts of illnesses they might have, and why they were there, what were they doing while they were there, what is their occupational risk. So for example, someone who's been out somewhere or other, whatever that gathering might be, or actually very in terms of refugee camps or elsewhere, if there was someone who was out there involved in healthcare, involved in social care, their exposure risks are likely to be greater than other individuals. Who they are, as I said before, pregnancy, immunocompromised, vaccinations and prophylaxis. And what they did when they were there is really, really critical, particularly things like food, water, hygiene, medical treatment, and sexual risk, which has been mentioned a couple of times, but not really anything I've discussed in detail yet. Very quickly, when we're thinking about infections, a lot of things may happen very quickly and will be dealt with on the ground at the events. If there are big respiratory virus outbreaks like influenza, there will be people getting sick during the event, and the people on the ground will be dealing with that. Gastrointestinal infections, very common. The viruses will spread very quickly, salmonella from food-borne infections. Some of you may remember in the last round of the Winter Olympics, various athletes couldn't take part because of a norovirus outbreak within the Olympic camp. Those types of things happen. And then when we see the returnee, we have things that may happen quite quickly, and they might be things which are related to the crowded environment people are, it may be related to the gathering, it may be related to what's happened there, or it may just simply be related to the part of the world where they are. Things like dengue, chikungunya, and transmitted by mosquitoes, malaria again, and various bacterial infections going through. But I think what we don't think about as much is some of the chronic and longer-term risks. We've had in the questioning earlier on a bit mentioned about transmissible viruses, which I think is a very important thing. HIV, hepatitis B and hepatitis C. And as always, we're often constrained in how we think about patients by some of the ways we've heard about things as they go through and these diseases have evolved. So if you ask most people who work in the UK healthcare about hepatitis C, for example, they will say intravenous drug use, blood transfusion before 1989, and tattooing. That's your risk factors, that's who gets it. We down at Ealing, and I'm sure my colleague at St Mary's will do, we see a lot of people from the subcontinent who've got those viruses. They don't have any of those risk factors. They have no idea how they caught it. Most of them have probably caught it through some breach of medical or injecting or bloodborne transmission, which could involve the sorts of practices that we heard earlier on. But actually getting over the stigma that's linked to hepatitis C is actually quite difficult, because people do think that it's predominantly a drug-using disease, which is in some populations, but not in others. So, what we think about outbreak contenders, this is just a quick picture about MERS. I'm sure MERS has been mentioned this morning. I was here this morning because I was in clinic. And everyone worries about MERS because of that potential for an outbreak. But the reason I'll show you this next slide is because this actually doesn't relate to a mass gathering, but it shows the potential if somebody comes with something like MERS from an area where it's endemic into an area where it doesn't exist. The reason MERS makes people so sick is it jumped across the animal species into humans somewhere around about 2012. And when we have a virus or another infection that moves from animals to humans, it tends to be more severe in humans because we haven't co-evolved with it over time. And what this graphic shows, it's targeted around about June of 2014, I think it was, is a single traveller, in this case a business traveller, coming back to South Korea, ended up within a very short period of time with a large number of cases, a large number of potentially exposed people, and a huge amount of hysteria. If you want to look in that time, you will see pictures of everybody on the street in Seoul wearing masks, people being afraid to go to hospital, and all of the impacts that that has. Now, the bit, I don't know if you can see it, but the bit that I particularly wanted to highlight with this is it was 11 days after that traveller returned from, I think it was from Saudi into Seoul before the diagnosis was made. The biggest virus which is likely to give us a big outbreak is, of course, influenza, and this is one which again doesn't stem from a mass gathering, but does actually show you just the impact of a virus which we're not used to if it's introduced into a population. And this is the timeline for the 2009 influenza pandemic. April the 2nd, the first case was in Mexico. The first case in the UK was on April the 27th, and by early May there was transmission in the UK. By June, the World Health Organization had declared a pandemic because it was now in every continent in the world. And by August, it had all slowed down. And if you look at the impact of that on your healthcare system, these are two graphics that came from the impact on healthcare in London during the period of time of the H1N1 coming through. The left-hand side is admissions for influenza to hospital, and the right-hand one is intensive care unit bed occupancy. And we completely log-jammed in London for intensive care unit beds at that time, which has a huge impact on healthcare. So I think that leads to something which I think links a little bit to one of the talks earlier on about the panic and fear about people going to mass gatherings and when they come back. And actually, we're more likely to get these sorts of things from regular day-to-day travellers. Globally, people travel much, much more for tourism and for business than they'll ever travel to mass gatherings. Mass gatherings just give certain and particularly high risks. But this is a final graphic on that bit that says about what worries me the most going forward, which is something which isn't talked about as much, which is the gradual spread and emergence of highly drug-resistant bacteria. And this is a graphic from the New England Journal of Medicine about 3 weeks ago, which was talking about the outbreak of a highly drug-resistant strain of typhoid in Karachi, in over 1,000 cases in Karachi at that time. And that just shows you the timeline of the development of drug resistance. And when we have people who get together from lots of different cultural areas, and in areas where then you may get things occurring at that time like foodborne illnesses where people get given quite a lot of antibiotics, the potential for the acquisition, the transmission of drug-resistant bacteria and taking them home to your endemic, to your normal country becomes very, very high. And I don't really know how we deal with that going forward. I think it's a real challenge for every healthcare system. And I think it's something that, again, we should think about in terms of how we're trying to reduce the risk of fecal-oral transmission, which is how these bacteria spread. So I just thought I'd finish off by thinking a little bit about, as a clinician, seeing patients in my own practice in West London who have often travelled for all sorts of reasons. You know, what do we really want? What do we really need? So first of all, prevention. A lot of people have talked about prevention. We've got vaccines on the left there. Interestingly, the World Health Organization have rapidly deployed an experimental new typhoid vaccine to try to combat the outbreak in Karachi, which is more effective than current vaccines. So how quickly will that get licensed and get out there regularly? How quickly will that get to people who perhaps are going to vulnerable areas, both people going to mass gatherings and other things? We've got some anti-malaria prophylaxis at the top, standard hygiene in the middle, and condoms down on the bottom right. So, you know, we can't ignore the sex question. You know, mass gatherings are much more than just religious gatherings, and we know, for example, that for a number of years the Olympic Village has had free condoms in every athlete's room, acknowledging the fact that at that sort of mass gathering, those transmission events are likely to occur. And then we've got education awareness. So I've got my first stick figure there as a doctor. So I'm not too proud to stand in front of you and say that as an infectious diseases consultant, seeing people in West London for the last 20 years, lots of whom have been to the sorts of mass gatherings that you've been talking about, I had very little idea what actually really happens in the heart or the melon. And I learned quite a lot from the hearing about that earlier on. So we need a lot more education for our medical staff. We need a lot more education for patients and people who are travelling. And that education needs to be targeted. I said earlier on, the infection risks are different whether you're pregnant, whether you're immunocompromised, whether you're elderly, whether you have HIV. What sorts of things are actually affecting individuals? The people who organise these things, the summit in the middle there, I think have done a tremendous amount. We've heard a lot of that today to do those sorts of things going forward. And obviously the travel people, and down at the bottom right, the leaders, the people who are making decisions and thinking about these things. And also thinking about how those things go into an evaluation and understanding of health risk going forward. If we take our happy little stick person at the bottom left there, if we have somebody who needs a transplant, needs cancer chemotherapy, needs treatments for rheumatoid arthritis, for example, we need to assess their risk of infection to know what we need to cover them for when they're immunocompromised for those things, particularly tuberculosis. We could easily have someone who's born in the UK and under all of our guidelines will appear to be low risk. That person might have travelled to the Mela or the Hajj on a regular basis for 20, 30 years, and actually really under that circumstance, what is their tuberculosis risk? Should they fall into the high-risk group, and should we be covering them? I don't know the answer to that, but I think those are the things that we need to think about. Information, we can get information overload. Anyone's interested, that's a thrash metal American band, that's their CD. But in terms of that, we need to get information disseminated very quickly when there are outbreaks and when things are happening. So when something's happening at the Mela, how do we get that information to doctors all around the world who may be seeing people when they get back, and to the individuals who've been there? Social media is a good thing. It can be for positive and for negative, but there's probably a lot more that can be done on that. And finally, really the thing that holds infectious diseases back more than anything else is the lack of very quick, rapid diagnostics. Diagnostics can be done right by the patient when things are happening that can tell us what the infection they've got very quickly, and therefore we can take the appropriate infection control, isolation and treatment, and most importantly, not give them the wrong treatments. So that's me done, and just actually without any collusion with our colleague who was doing it earlier today, I wanted to make a final positive note to say actually this shouldn't put anybody off going to mass gatherings. That's a very famous mass gathering which I'm sure people recognise. It was a big musical gathering from Woodstock in America in the 1960s, which is seen in America as almost a cultural revolution coming from that point. Some of that for good, some of that not for good. But actually, to encourage people to go to mass gatherings, but we all need to work to try to make people in mass gatherings as safe as we can and look after them when they come back. Thank you very much.